Good evening to everybody. So I'm going to be talking about breast cancer in patients who have a BRCA1 or a BRCA2 mutation. Slide number 4, please. And I'm just going to start off by looking at the incidence of BRCA mutations according to age of breast cancer diagnosis. So what we can see on this slide is that the younger the patient is at the time of breast cancer diagnosis, the more likely they are to harbour a BRCA1 and a BRCA2 mutation. So if we see a lady over the age of 60 who's been diagnosed with breast cancer, her chance of harbouring a BRCA mutation is approximately 7%. In contrast, if we look at a woman who is under the age of 30, her chances of harbouring a BRCA1 or 2 mutation is approximately 27%. This is also a little bit dependent upon ethnic origin. So if we were looking at an exclusively Ashkenazi Jewish population, this might be a little bit higher, and this might also be true for some Nordic countries or patients of certain Eastern European origin, where it's more likely that there are founder mutations. But what we can see here is that the chance of harbouring a mutation is higher the younger a person is at the time of breast cancer diagnosis. Slide number 5, please. And if we want to just give a quick overview of the clinical characteristics of a BRCA1/2 associated breast cancer, as I've mentioned, younger age of diagnosis is characteristic of this. We know that amongst women who are being screened because of a known BRCA mutation, these women are more likely to have an interval cancer. And interval cancer means a cancer that's diagnosed between screening episodes. So if a woman is normally screened once a year, an interval cancer would be a cancer that appeared between her routine screening imaging. We know that in terms of imaging, in high-risk women with a BRCA mutation, their breasts and their tumours are better visualised on magnetic resonance imaging, or MRI. This partly has to do with their young age. We know that women with a BRCA mutation are more likely to have bilateral breast cancer, and we know that BRCA-associated breast cancer has distinct histopathological features. Slide number 6, please. So if we're looking at screening and diagnosis, there have been a number of large studies performed on women who are considered high risk of breast cancer in many countries. So we can't go through all of these studies, but if we just focus on the Canadian study that I've highlighted in red, this was a study done on a cohort of exclusively BRCA-positive women. And we can see that in this case, if we're looking at the sensitivity of MRI compared to mammogram or ultrasound, there's a major difference here. So the sensitivity was 77% in this group of BRCA-positive high-risk women. And this is compared to a sensitivity of only 36% in terms of mammography use. In terms of specificity, so it doesn't really make much difference which modality is used, but the sensitivity is a huge difference between MRI and mammography in this high-risk group of BRCA-positive patients. Slide number 7, please. And if we look more closely at 2 studies in high-risk women that compares MRI with mammography, what's going on here? So what we can see is that the likelihood of a positive test is approximately 2 to 3 times that of mammography if an MRI is used. That means that we're recalling double the number of women to come back for further imaging or testing. It means that we're biopsying twice as many women. So in the Netherlands study, for example, close to 3% of the women were coming back for biopsies as compared to only 1.3% in the mammography group. And in the MRI group, we're detecting double the number of cancers. And we're also having less false negatives. So there is a price to pay for MRI. More women are getting biopsied, but there is no question that we are detecting more cancers in this high-risk group of women. Before I go on, just to remind you all that you can ask questions and send comments at any time during the session. Slide number 8. So why is it that MRI is superior to mammography in BRCA-positive patients? So there are a number of explanations. The first is that BRCA-positive breast cancers are often in younger women, and we know that younger women have denser breasts. We know that the sensitivity of mammography is inversely related to breast density. So the younger a woman is, the less sensitive a mammography is going to be in her case. Therefore, MRI is more useful in these cases. But there are also other features that make MRI superior in BRCA-positive patients. For example, in women with a BRCA-positive breast cancer, they have what is called pushing margins rather than serous irregular margins. So they may have a more benign appearance of their tumours on mammography. And the other issue is that BRCA-positive tumours are less often associated with ductal carcinoma in situ, and often DCIS have associated microcalcifications. And microcalcifications are often better detected on mammography. And so these women, if they're having less DCIS and less microcalcifications, we may be less likely to pick up on these tumours on mammogram. And this is particularly true for BRCA1-associated tumours. Slide number 9, please. In terms of histopathological characteristics, we'll divide BRCA1 and BRCA2 first of all into two groups. So we know that the BRCA1-positive tumours are often what we term today triple negative, which means they have no estrogen or progesterone receptor expression and that they have no HER2 overexpression, often what's termed a BRCA-ness of a tumour. Whereas a BRCA2 tumour is usually endocrine responsive, but not always. And other features that are shared by BRCA-associated tumours include a high grade. They're mostly of invasive ductal carcinoma. We don't often see invasive lobular tumours in BRCA carriers. We may see particular subtypes such as medullary carcinoma. As I mentioned, often on histopathology there are pushing margins. DCIS is less common. We may often see a lymphocytic infiltrate, and that's a very hot topic at the moment. And these tumours may be more likely to harbour a p53 mutation, to be of basal phenotype, have EGFR expression, and may be c-MYC amplified. Next slide, please. And in fact, we can actually predict the chances or the probability of harbouring a BRCA1 mutation by pathological features. So this is a paper published by Lacani's group. And what they did was they saw that if you look at ER status and grade and age, you could predict the likelihood that the patient was harbouring a BRCA mutation. So if the patient was under the age of 30, they had an ER-negative tumour, and they had a grade 3 tumour, the chances they were harbouring a BRCA1 mutation was approximately 35%. And I think what this slide is showing us that we can sometimes, if we have more limited access to genetic testing, which we don't have in our country, but some countries might have, we could probably use some of the pathological features along with age to help direct us which patients most certainly need to have genetic testing done at the time of breast cancer diagnosis. Next slide, please. In terms of the impact on treatment decisions, there are many, many issues that need to be considered. So if we start off about local management, one of the big questions that arises is, should these women with a BRCA mutation, should they undergo lumpectomy or mastectomy? So one of the things that comes up is that often at the time of surgery or initial primary surgery, these women often don't yet know that they harbour a BRCA mutation. So this raises a question of when should BRCA mutation testing be performed, and this may be associated with the age of diagnosis. So is it necessary? Should all women have BRCA mutation testing up front when they're diagnosed with breast cancer, or should this be dependent on their ethnicity or their age? The other issue is, should these be women being offered a bilateral mastectomy up front the minute we know that they have a BRCA mutation? So should they be having a therapeutic mastectomy and a contralateral prophylactic mastectomy? And many of these questions do have to depend on their stage. So if we're going to be dealing with a woman with a BRCA mutation, but she has a stage 1B N0 tumour, which means she has a tumour that's under a centimetre and clear lymph nodes, this woman has a very good prognosis regardless of her molecular subtype. And so it would be reasonable to start thinking long-term about her local management and her future risk of another local tumour. And that would be a case where it would be very reasonable to think about mastectomy and even prophylactic mastectomy of the healthy breast. But if we're looking at a woman with a high-risk tumour, so she might have extensive lymph node involvement and a large tumour with unfavourable features such as a triple-negative breast cancer, this would be a woman at very high risk of distant recurrence. And we need to remember that local management such as mastectomy probably doesn't have an impact on the risk of distant recurrence, and it may not be reasonable to have such an aggressive local management approach at a woman whose risk is very, very high for distant disease. The next issues that need to be considered are systemic therapies, and we'll look at that a little bit more closely. But it is important to point out that to date, we don't have any evidence-based medicine that we need to change adjuvant chemotherapy if we know that there is a BRCA status present. There is increasing evidence to support the use of DNA cross-linking agents and alkylating agents, such as platinum agents. There is some suggestion that mitomycin might be of use. And there are some retrospective studies suggesting that CMF, which was based on cyclophosphamide, methotrexate, and 5-FU, might be more effective in BRCA-positive patients. And the final issue that's very important to consider when managing a patient with a BRCA mutation is the issue of fertility. Why do we need to consider this? Well, these women are often younger than sporadic breast cancer cases, so they may not have completed their reproductive years, and they may not have yet had children or completed their family planning. We have to keep in mind that we would like these women to have their ovaries removed because of their ovarian cancer risk, preferably before the age of 40. And there are other issues that we'll discuss later on in the session about fertility considerations in terms of what the best options are for a woman with a BRCA mutation. And finally, a woman with a BRCA mutation may want to also consider the option of pre-implantation diagnosis and only implanting embryos that don't have a BRCA mutation, although this is highly controversial on an ethical level. Next slide, please.
Shani, thank you. It's Fedro speaking now. I have some questions from the floor. So the first question is regarding your service, actually. You are heading a breast cancer service for young women, and some of our listeners are interested in knowing how have you organized that, if you offer genetic counseling straight away when you have a young breast cancer patient, if you have a fast track for the results of BRCA1 and BRCA2 mutational status.
Okay. So we have a dedicated young women's service in our centre. We're very fortunate. And that includes in-house, literally the rooms right next to me, in-house genetic counselling and testing performed by a geneticist, in-house fertility preservation and consultation. And this is very, very important because these issues need to be addressed earlier on, as early as possible in young women. So the genetic testing should ideally, I think in an ideal world, these women would be referred as soon as they were diagnosed by the surgeons. But in reality, that doesn't happen. I refer all the women for genetic testing as soon as they arrive to the unit, and I try and ensure that they all have it done early on. This way they can make better decisions about their surgical management. So even if they come to me after their lumpectomy, some of these women actually choose, if they know that they have a BRCA mutation, instead of having radiotherapy after their chemotherapy, some of them might choose to go on and have a mastectomy instead. So we try and get our genetic testing done early on. We're of the philosophy that genetic testing is best performed after genetic counselling, and we prefer that this is performed by a geneticist, but this is a luxury we have in our unit. The other thing that's very, very important is the early referral for fertility preservation. The earlier these women are referred for fertility preservation, the better chances our specialists have of optimizing this process, because then they have more time up their hands. So if I have a woman referred to me with a triple-negative breast cancer, I might want to start her systemic therapy as soon as possible. So the earlier she's seen, the better in terms of how much time I can buy to do her fertility preservation. So we try and do as much of this in-house and as fast as possible, and when necessary, we can actually have our genetic testing done with a 1-week turnaround.
Yeah, thank you very, very much for sharing your experience. I have another question from Dr. Garbett from UK, and he wants to ask a couple of things. The first one, what is the percentage of BRCA1, BRCA2 mutation carriers that you see in your clinic? And the other one, if you do some kind of, if you use some criteria to, let's say, put forward the test for the young women that you see in your clinic. So do you use any criteria to make an estimation of the probability of being a mutation carrier?
In terms of providing the women with a probability or an estimate of their risk of actually harboring a mutation, our geneticist does that. Again, we're very lucky that we have an in-house geneticist. In terms of how many BRCA patients we see, you have to keep in mind that half of my patients, or half of my young patients, are of Ashkenazi Jewish origin, which means that of my patients who are under the age of 40, I'd say if they're of Ashkenazi Jewish origin, at least 30%, if not higher, are actually going to harbour a BRCA mutation. Of the other half of my patients who are of non-Ashkenazi origin or under the age of 40, their chances of harbouring a BRCA mutation is much lower. I also see, because we're a referral centre, I probably see a higher percentage of BRCA-positive patients than would normally be seen in a standard centre. But it is rather high. So I'd say that for my young patients under the age of 40 who are Ashkenazi Jewish, I'd say around 30%, maybe slightly higher, would be BRCA-positive.
Thank you very much. Last question from the floor. This comes from over the ocean, from Chile. And our friends from Chile ask whether you also refer your breast cancer patient to the gynecologist for the follow-up of the, let's say, risk of ovarian cancer and primary peritoneal cancer. Do you do that straight away when you see the patient the first time, or you do it in the follow-up after the diagnosis?
If the patient is under the age of 40 and they're in the process of active treatment, I make sure that they're at the gynecologist within several months. If they're over the age of 40, I urge them to see a gynecologist as soon as possible. If they have to have active chemotherapy, we arrange that they have their surgery immediately at the end of their chemotherapy. Once again, we have the luxury that we have in-house gynecologists in our unit once a week. In addition, we also have in our centre a risk for women who are at high risk of breast and ovarian cancer, and that's a clinic that caters specifically for women who harbour a BRCA mutation. Most of the women there are healthy women, but some of them are women who have already had breast or ovarian cancer. And in this clinic, which is very unique, the women can come in twice a year. They come in on one day, and on the one day they are seen by the surgeon, they are seen by the gynecologist, they have their CA125 tested that day, they have their breast imaging that day, and they have their vaginal ultrasound that day. So they have their whole workup covered in one day, concentrated in one clinic, and the opportunity to go in again to speak with the geneticist if any issues have come up during that time. But again, we're very lucky that we have that service, and it's probably the best way for a BRCA-positive patient to be managed, whether they're healthy or whether they've had cancer before.
Wow, congratulations, really. Go ahead on your presentation, please, Shani.
Okay. So we'll go through the systemic therapies. So slide number 14. Now, before I discuss the systemic therapies, I just want to give a little bit of a background about DNA damage and repair, because it helps give an understanding about our choices and considerations with systemic therapy. And I'm just going to focus on single-strand and double-strand breaks. So if there's a single-strand break in DNA, so generally the repair pathway is a base excision repair, and the key enzyme in base excision repair pathway are PARPs. PARPs are poly-ADP ribose polymerases. When we're looking at double-stranded DNA breaks, so the important repair pathways are the recombinational repairs. And we're just going to focus today on the homologous recombination, where the repair enzymes there are ATM, RAD51, and BRCA1 and 2. Slide 15, please. So in terms of homologous recombination repair pathway, it's a very important pathway for repairing replication lesions. It's dependent on the RAD51 family of proteins, and it makes use of homologous DNA sequences. And in this pathway, BRCA1 and 2 enzymes play a very, very important role. So you can imagine that if a patient is deficient in these BRCA proteins, they're going to have a problem repairing their double-stranded DNA breaks. So with that in mind, we'll just discuss chemotherapy. So on to slide 16, and sorry, now on to 17. So in terms of chemotherapy, there are preclinical studies that suggest an increased sensitivity to agents that damage DNA in a way that interferes with DNA replication forks, and which subsequently require DNA repair by homologous recombination. And that makes sense, because if we can induce DNA damage and then the tumour doesn't have the ability, or the cell doesn't have the ability to repair that damage, then the cell will have to die, and that would actually make the chemotherapy very effective. So agents that are DNA cross-linking agents, such as platinum agents or mitomycin, there is a lot of preclinical studies suggesting that these are very effective in patients who harbour a BRCA mutation. However, the clinical evidence to support this exists but is very limited, and we have very, very little prospective data to support this information. If you speak to a breast oncologist who manages these patients, we will all tell you that we think the platinum agents are working better in these patients. But once again, we have very little prospective data. It's very limited, and therefore we don't have, at least in the adjuvant setting, any data to suggest that we have to change the management of these patients at present, and this will hopefully change and we'll have more data in the near future. Slide number 18.
Yes, Shani, sorry if I interrupt you, but there is another question coming from the floor.
Sure.
And this regards the use of platinum compounds and maybe combination, I would add, in neoadjuvant setting, because you are, of course, aware that the data about complete response in BRCA1 mutation carriers and in more general triple negative, the percentage of complete response, pathological complete response, is quite high. Can you comment, is there a specific regimen that we should use in these patients, at least in the neoadjuvant setting?
This is a really interesting question, and this is something we discuss in our unit every week in our staff meeting. And, there have been a number of studies that looked at use of platinum agents, not specifically in BRCA-positive patients, but in triple-negative cases. There was a German study presented last year, but they didn't use a conventional chemotherapy protocol. But if we just look at the CALGB trial that was presented at San Antonio in the recent conference, so that looked at combining carboplatinum with an AC Taxol regimen. And there was no question that these patients had a superior pathological complete response. So my question to that is, how much more are we going to improve survival with each incremental increase in pathological complete response? We know that pathological complete response is a surrogate for survival in triple-negative breast cancers, but where's the upper limit? So I'm not sure that we have enough data yet to always incorporate a platinum agent into neoadjuvant care, because I don't think we have the data yet to tell us that it's translating into a survival benefit. We'll probably have that data in the next year or two, but the data isn't there yet. We consider incorporating platinum agents in some of our BRCA triple-negative cases if the patient has very aggressive local disease and we're concerned that they're at very high risk of having residual disease. But I think we need to be cautious about the data that's been presented so far, because we don't yet have survival data beyond the pathological complete response.
Yeah, thank you very, very much. And please go ahead with your presentation.
Okay. So now we're moving on to PARP inhibitors, so slide number 20. So the PARP is a superfamily of proteins which have multiple members, and they have a diverse functions, including DNA repair, telomere maintenance, epigenetic regulation, and centrosome function. And PARP1 is a key enzyme involved in the repair of single-stranded DNA breaks, and it plays actually a very key role in the base excision repair pathway by binding directly to sites of DNA damage. And it's also important because it helps recruit other DNA repair enzymes. So if we inhibit PARP1, we're going to increase the double-stranded DNA damage. So if we simplify this model as much as possible, under normal circumstances, if there's a single-stranded DNA break, PARP comes along and fixes this break. However, if we inhibit PARP, we are not going to be able to fix the single-stranded DNA break, and the default in these cases, if we can't fix the single-stranded break, then a double-stranded break is going to take place. And this is where things get interesting, because if the BRCA proteins are functioning, they will come along and they will fix the double-stranded DNA break. But if they're not functioning, we're going to have a problem, and this is the case in women with a BRCA mutation. So if we just look at this PARP inhibition pathway and we think about what's termed synthetic lethality, we can see that if a patient has normal BRCA1 and 2 and we inhibit the PARP enzymes, So the BRCA1 and 2 will correct the double-stranded DNA break, resulting in chromosomal stability and cell survival. However, if we inhibit the PARP by a PARP inhibitor and the patient doesn't have functional BRCA1 and 2, the patient will not only will the single-stranded break not have been fixed, they will not be able to repair the double-stranded break that results from that. And this will result in chromosomal instability and cell death. And this is the logic behind giving a PARP inhibitor. The logic behind a PARP inhibitor is how do we take advantage of these patients' BRCA mutation in order to attack their cancer cells. And if we want to simplify this model, so we could say that by inhibiting a PARP inhibitor, it's like destroying a parachuter's main parachute. Now, if a parachuter is parachuting out a paratrooper, then they will have a reserve parachute. But in the case of BRCA patients, they don't have a reserve parachute because their BRCA proteins aren't working. So if we destroy their main parachute by a PARP inhibitor, they can't rely on their reserve parachute because they don't have functional BRCA protein, and the result of that is cell death. And that is why PARP inhibitors are thought to be very promising in the treatment of BRCA-positive breast cancer. Okay, so the main parachute would be like we would destroy that with a PARP inhibitor. The BRCA mutation means that there's no reserve parachute, and then we end up with death of the cancer cell. Slide 28, please. And there is preclinical evidence of increased sensitivity of BRCA-positive cell lines to PARP inhibition. And what we can see here is that there is no difference in the sensitivity between a heterozygous and a wild-type BRCA cell. But if you have a look at the cells that are BRCA1 or BRCA2 deficient, okay, so there's loss of heterozygosity, these cells have very high cell kill when they're given a PARP inhibitor. So this is great in theory, but does it actually translate into the clinic? Slide number 29, please. So there was a phase 2 proof of concept study published in The Lancet by Audet et al. This was published in 2010, and this was by Andrew Tutt's group. And they took patients with refractory advanced metastatic breast cancer who had a proven BRCA1 or 2 mutation. Most of these patients had received at least 3 lines of chemotherapy. And there were 2 groups in this study. This was not a randomized study. This was a study looking at the optimal dosing regimen of olaparib. So we're just going to focus on the 400 milligram BD dose because that's the accepted standard dose today. And interestingly, we're seeing that these patients had a 33% objective response. Remember, these are heavily pretreated patients who have failed at least 3 or 4 previous lines of chemotherapy. This is a very impressive response rate for a single-agent biological therapy with no chemotherapy. And this has been the basis for many other studies. There are many ongoing studies of PARP inhibitors in metastatic patients with BRCA-positive mutations, and there are currently in the planning studies that are about to commence looking at adjuvant use of PARP inhibitors in women who have had early-stage breast cancer who harbor a BRCA1 or 2 mutation. Next slide, please. Fedro.
Okay, Shani, I'm Fedro. I have another question from the floor, which regards the different PARP inhibitors. We have a number of molecules, actually, which are into clinical studies. Olaparib, rucaparib, BMN 673, and also iniparib. Can you comment a little bit about the negative results of iniparib? Maybe this is not really PARP inhibitor, but can you comment on that?
I think you've answered the question for me. I mean, there were originally some very exciting phase 2 results with the iniparib in combination with gem and carbo. And the phase 3 results came out and were very disappointing. It was a negative trial. But the thought is that iniparib is actually not a PARP inhibitor. I know that Professor Kaufman in our department is very involved with many of the PARP inhibitor trials, has come back from most meetings, and the general thought is that it's actually not a PARP inhibitor. So I think we can put that aside, and that's probably the only main negative trial. In terms of the other molecules that are being studied, we don't really know yet which the best PARP inhibitor is. We're just waiting for more study results for that.
Okay. Thank you very much. Go ahead, please.
Okay. Next slide. So we're going to look at prognosis in BRCA1 and 2 breast cancer. So on to slide number 32. So we're going to divide looking at prognosis into two issues. We're going to look at local disease and we're going to look at metastatic, and we're going to look at systemic disease. So we know that in terms of local disease, there's a greater incidence of contralateral breast cancer. This is a study by Laurie Pierce that was published in the JCO in 2006. And at 10 years of follow-up, women who had a BRCA mutation had a 26% chance of having a contralateral breast cancer compared to 3% in the non-carriers. So these women are most certainly at increased risk of contralateral breast cancer. In terms of systemic relapse, though, there are a number of large retrospective studies, and all of these studies are consistent. Most of these studies report that there is no difference in overall survival between patients who harbour a BRCA mutation and those with sporadic breast cancer in terms of overall mortality or breast cancer-specific survival. And three key studies are the study by Gadi Reinhardt from Israel, which was published in the New England in 2007, and two more recent studies by Goodwin and the Polish group that were published in the JCO. And we're just going to look at one of these slides, which is the paper, slide number 34, please, by Goodwin group that was published in the JCO in 2012. What we can see here is that the BRCA-positive patients in the upper two sections, in A, B, C, and D, are in blue, and the sporadic cases are in yellow. And in the cases of both BRCA1 and BRCA2 breast cancer, there is no difference in 10-year prognosis between women who harboured a BRCA mutation and those who had sporadic breast cancer. I think it is interesting to note that when you look at the details of this study, the BRCA1 patients and the BRCA2 patients were actually more likely to have received adjuvant chemotherapy. And despite this, there is actually no difference in long-term survival between these two study groups. Next slide, please.
Shani, I have a question about this trial. In this trial, the patients were divided according to their mutation status, so BRCA1 and BRCA2, did not behave exactly the same. Do you have any comment about any differences in the clinical behavior of BRCA1 or BRCA2 mutation carriers?
Okay, so at the moment, we need to keep in consideration a number of things. BRCA1 patients are more likely to have a triple-negative breast cancer, so they're more likely to have more aggressive biological features. And I'm not familiar with studies that specifically look at comparisons between BRCA1 and BRCA2, but in general, the general thought is that the patients who are having the BRCA1 mutations, whether it's the 185 DLAG or the 5382 insertion C, the thoughts are that these women often have a more aggressive breast cancer, but there's very limited data out there. And keep in mind that the BRCA2 patients are often hormone positive, and hormone positive patients will usually have a better prognosis than triple negative. But if you look at BRCA2 patients who have a triple negative breast cancer, they're probably going to do very similarly to a sporadic triple negative breast cancer. So at the moment, we don't seem to think that it matters whether it's a BRCA1 or BRCA2. We think that what's important is still the molecular subtype, irrespective of BRCA mutation, but the data is limited.
Okay, that's very interesting. I think we still have to learn a lot about the differences of these two genes, which actually may have different phenotypes, as you well underlined. Okay, Shani, go ahead, please, with your presentation now.
Okay, so slide number 35. We're going to look now at a case. I thought it might be a nice way to finish off the session and talk through a case. So this case is slide 37, please. A 32-year-old woman who palpated a mass in her right breast. On ultrasound, she had a benign-looking 1-centimetre lesion and suspicious axillary lymph nodes. But on clinical examination, she had a 4-centimetre mass in her breast with palpable fixed axillary lymph nodes. And this illustrates that often we're going to see an inconsistency between the clinical findings and traditional imaging modalities such as mammogram or ultrasound in a young woman, or particularly one with a BRCA mutation. The patient had a systemic workup and there was no evidence of distant disease. So if we summarise, this woman had a clinical T2N2 M0 case of breast cancer, so she's stage 3. She had a biopsy performed and she had a high-grade invasive ductal carcinoma that was ER, PR and HER2 negative. So she has a triple negative stage 3 tumour. The patient has genetic testing done when she arrives in our unit and is found to have a BRCA1 mutation. The patient also does not yet have children. This is a patient who is going to need chemotherapy. she's going to need surgery, and she's going to need radiotherapy. So we're going to have a lot of management challenges in this case. So in terms of her fertility preservation, this is a woman who doesn't yet have children. In a young woman with locally advanced disease, even after adjuvant therapy, we're going to suggest that she put off any pregnancy by 2 to 3 years. And we don't do this because we think the pregnancy puts her at risk. We do this because her risk of developing a distant recurrence in the first few years is very high. And we don't really want to find ourselves with a pregnant patient who's just developed metastatic disease. So we're going to ask her to put off her fertility or having children, say, to the age of 35 in this case, because she's a 32-year-old. And she has locally advanced triple-negative disease. So I want to start her chemotherapy as soon as possible, and she's also an ideal candidate for neoadjuvant chemotherapy. So one of the questions that comes up is, how much time do I have in a patient like this to perform fertility preservation? So that's a very big issue that we have to deal with. The other issue is that how likely is this chemotherapy to actually damage her fertility or put her into menopause at the age of 32? If we give her a standard dose-dense regimen of AC and Taxol, which is our unit's policy, her chances of having premature menopause is still relatively low. It would be probably not more than 30%, but I'd be happy to hear what Fedro has to say because that's his area of expertise. Then the other issues, once we've given her the chemotherapy, is what sort of surgery should this woman have? Should we be giving her, if she's had a great response, should we just stick to conservative surgery and give her a lumpectomy because she's at high risk of distant recurrence? Should we give this woman a mastectomy? And what if this woman wants to have a bilateral mastectomy with a prophylactic mastectomy? Do I want this woman spending the next year or year and a half having repeated surgical procedures because the reconstruction never finishes with one procedure when she's really at high risk of developing metastatic disease? So do I want her spending a lot of her next year and a half in and out of hospitals for aesthetic reasons when she's at high risk of systemic disease? And can we consider using nipple-sparing mastectomy in a woman who's already had breast cancer, who's BRCA positive? She's a young woman, she may not be married, and having mastectomy with the removal of her nipple may be very traumatic for her. So a lot of issues come up when dealing with a young woman, and in particular a young woman with a BRCA mutation. And then finally, the issue of the timing of her oophorectomy is going to be a major issue. So there is some controversy about when these women should be having the oophorectomy if they have a BRCA1 mutation. Should it be at 40? Well, there are some people that think that these women should have their ovaries out already at 35. So what implications does this have also in terms of her fertility? And when we talk about her fertility and fertility preservation, there are many options today for fertility preservation. One of the options for fertility preservation is the option of doing a wedge resection of ovary for future reimplantation. However, we're very wary of doing that, and in fact we don't do that in Israel at least for a patient with a known BRCA mutation because of the concern that there could be occult malignancy in the ovarian tissue. So her options in this case as a BRCA positive young woman would be more limited than a young woman without a BRCA mutation. In other words, I think what we're just trying to give an overview of here is that managing a young woman with a BRCA mutation in particular is challenging. It requires multidisciplinary care and teamwork, and there are many, many considerations that have to be taken into account in these cases. Fedro, do you have any questions? Next slide.
Yes, I think this is your last slide, and I also add my thanks to this very excellent presentation. Yes, I do have a question. This was a very provocative case because, and underlines the complexity of managing these young women with breast cancer, particularly if they have a BRCA mutation. And as you said, there is not really the right receipt because, for example, we find sometimes very difficult to bring all these issues together just around the time of diagnosis. And for example, some of our patients do not really want to have a BRCA1, BRCA2 test right away because they prefer to dilute somehow the information that they receive and the decisions that they have to take. And again, I think that what you have done in Israel to build up a service which is dedicated to these specific situations is very good, because multidisciplinarity is key. The correct timing of referral is key, particularly for fertility preservation. The fast track in having the information about the genetic test is key if you wanted to use that information for, let's say, for deciding, for example, the operation. And I do agree with you when you said that in this specific case, maybe a bilateral mastectomy was not the best option, because we always have to remember to put, let's say, the risk of the contralateral breast within the context of the risk of metastatic disease, particularly when you have an aggressive tumor, like in your case. I just have one other question from the floor, which comes from Montenegro. And in Montenegro, apparently they do not have the facilities to test for BRCA1 and 2, but of course, when you do the clinic, you are faced with patients with a very high probability of having a mutation because of the family history, because of the young age at the diagnosis. So how would you manage a family like that, in which there was a previous diagnosis of breast cancer in 2 family members, and in which the age at the diagnosis was early, was before 40. So how do you manage patients in which you do not have the information of BRCA1 and BRCA2, or even you have the information and it is a negative test, but you have a very strong family history?
Okay. So I think there are a number of issues that can be considered here. If there is a family history of ovarian cancer, I think it's reasonable, even if there's no genetic testing available locally, to recommend that these women have their ovaries removed at 40 if there's a family history of ovarian cancer, because then the chances that there is some sort of family mutation, such as either a founder BRCA mutation or a private mutation, is very high. In cases where there are very high risk families with many or multiple breast cancer cases and the BRCA testing is negative, assuming that there's genetic testing available, what goes on at the moment in our case is that we have the option of sequencing the BRCA1 and 2 genes looking for private mutations, and we also have the possibility to refer the patients to have multi-panel testing for lower penetrance genes. But I'm guessing that if in Montenegro they don't have BRCA1, 2 founder mutation testing, they're not going to have access to sequencing or to panels of lower penetrance genes. So I think that if a patient has a very, very rich family history of breast cancer and early onset breast cancer, and there's no genetic testing available, I think they should be treated in terms of their imaging and follow-up of examination like a high-risk patient, unless proven otherwise. In terms of their ovaries, I'm not really sure what to tell you. If there's no history of ovarian cancer and that they're under the age of 40 and they have a hormone-negative tumor, I'd be very reticent to recommend that they have their ovaries out, because it's a huge price to pay for these women. If, on the other hand, they were around the age of 40 and they had a hormone-positive breast cancer, and I really thought that there was a very high chance of a BRCA mutation, and there are different sorts of online models that can be used to assess the risk that there's a BRCA mutation, I would discuss this with the woman, and I would give some consideration to ovary removal, particularly if she's had chemotherapy and we've put her into menopause anyway, so then the price is much lower to pay for that. But it's very challenging.
Yeah, by the way, I do agree. We see everyday patients with a strong family history, maybe not the BRCA1, BRCA2 mutation, and sometimes they have gone through chemotherapy and they do not have an ovarian function, and maybe they have a family history also in some second-grade relatives of ovarian cancer, and then those patients we suggested to go for bilateral salpingo-oophorectomy. I mean, we should be practical sometimes when we do not have really strong data, and use the common sense and the patient talk, and to discuss with patients what's best for them. I have another question from the floor, and it relates to the follow-up of patients who received adjuvant treatment for breast cancer. Do you have a more intensive follow-up for distant mets in these patients compared to the non-carriers, or you just use the common guidelines for follow-up?
We use regular guidelines for follow-up. Unfortunately, there's no evidence that early detection of distant disease changes outcome in any age group. So our follow-up, we basically do our follow-up as per NCCN guidelines, which is the same for all patients of all age groups, and that they see us in the oncology unit every 3 to 4 months for the first 2 years, and then afterwards 6 monthly till 5 years, and then annually after that. We do breast imaging more often in BRCA-positive patients, but this is not purely guideline-based. I'm just saying what we practice in Israel, and this is different in other places in the world. But BRCA-positive patients in our country can have an annual MRI. So we perform MRI once a year, and they also have a mammogram and ultrasound done once a year. So these women end up having imaging done every 6 months if they've had breast cancer and they harbour a BRCA mutation. If they haven't had breast cancer and they're healthy and they've got a BRCA mutation, in general they'll be having an annual MRI. In terms of addition of mammography, often what our radiologist does is she suggests that after the age of 40 they have a baseline mammogram done, and then she makes a recommendation to us based on the density of the woman's breast if there's value in continuing mammography. But in our country,
Yes.
all BRCA-positive patients receive an annual MRI from our health system.
Yeah. Yes, that's the same also in Italy. Okay, thank you very much. I think that we did our time, so it's our time has gone. It's very interesting, I must say. Congratulations for your presentation, and I think we can close here the session. Thank you, Shani.
Thank you very much, Fedro, and the people in the audience are welcome to use my email address if they have any questions they'd like to ask in the future. Thank you very much.